Welcome to Working with Homelessness in Hospitals, a brief training programme. This is module 1 of 3 modules, and this first module is an introduction, an overview to homelessness and health. Module 2 will focus on giving you a brief introduction to housing law, and module 3 will give you some top tips as to how you can make a difference to people experiencing homelessness when you meet them in hospital. All the modules have a 20-minute video, but then afterwards you can download the presentation as a PDF and go through to the links to learn more. And at the end of each module, there's 5 key questions which will help you review what you have learned. So my name's Sam Dorney-Smith, and I'm a nursing fellow for the Pathway charity. The Pathway charity lobbies for better healthcare for people experiencing homelessness and lots of other people who have difficulty accessing healthcare. If you have any questions at the end of these modules, please do feel free to get in touch, and that's my email address at the bottom there. So first of all, let's think about who is homeless. And I'm sure when you hear that question, that an image like this will come up in your head. But actually, a wide variety of people are homeless. Not just people sleeping rough or living in night shelters, also single homeless people and families living in hostels, temporary accommodation and bed and breakfast hotels. There's hidden homeless people, and that generally means hidden from statistics. And that includes sofa surfers, squatters, people who sleep on buses and in fast food restaurants, some boat dwellers and gypsies and travellers if they've got nowhere permanent to reside, people living in sheds, and some people living at work. And the statutory definition also includes people threatened with eviction within 56 days. So I'm just going to focus on what it means to be a sofa surfer just for a minute. A sofa surfer is someone who moves between relatives, friends or acquaintances, and they don't have anywhere permanent to stay. And we know there's been a huge rise in this recently, particularly amongst our young people. And I just wanted to give you a quick case study with a quote from a young female sofa surfer. I banked on the fact that colleagues wouldn't notice that I essentially rotated the same 3 work outfits each week, and that a bright slick of lipstick would draw attention away from my ensemble. But the unironed tops and whispered phone calls eventually gave me away. And the reason I profiled this is just that it's not just about being hidden from statistics. It's often when people are homeless that they feel embarrassed about it, and that you may need to be quite sensitive and understanding in order to understand that they are homeless, but also you need to do that in order to kind of understand the health risks that might be associated with that. So we know that homelessness is rising in England. So in December 2019, Shelter said that there were 280,000 people in England that were homeless. And a further 200,000 were reported to have been threatened with homelessness during that year. In terms of rough sleeping, our best statistics come from London. So for 2019, 2020, 10,726 people were seen rough sleeping during the year. And this was a 21% increase on the year before, and a 170% increase on 2009, 2010, over 10 years. And in 2018, the big issue suggested that there were at least 300,000 people in England that were hidden from statistics. So if you add this up, we're at least 500,000, possibly 750,000, possibly even 1 million people in England who would be classed as homeless. And the reasons for the increase in homelessness are probably fairly intuitive. So there's a lack of appropriate housing stock. Welfare reform has meant that some people have had difficulty accessing benefits. Austerity has caused many hostel closures, and we've had migration from Eastern Europe. And now we've got the dual impacts of COVID-19. Now, lots of people will know that there's been an Everyone In programme, and this has been helpful, with the government reporting that 29,000 people were brought in temporarily during COVID. But it is important to note that for many people that has been temporary, and night shelters unfortunately have not been able to open this winter, and we're seeing lots of new people losing their jobs and being evicted. So it's important to note that homelessness has not been solved and is still a real issue at the moment. So Whilst homelessness has been rising, hospital attendances from homeless people have been rising as well. So this piece of work by the British Medical Association called Streets of Shame was published in 2019. And what they demonstrated in their data was that the number of people going to A&E had tripled over the 7 years between 2011 to 2018. And this was followed by some NHS digital work that showed that admissions from people experiencing homelessness had gone up 6 times during 2008 to 2009 to 2017, 2018, so the same period. Just to say that any of these articles or whatever that are profiled on these slides, if you click through them on the PDF, you'll be able to go and read the articles. And that rise in homelessness is on the back of knowing already that people experiencing homelessness attend hospital more than the general population. So a very important piece of work done by the Department of Health in 2010 looked at all people that were no fixed abode that attended hospital in England. And that piece of work showed that homeless people attend A&E 5 times as much, were admitted 3 times as often, stay 3 times as long, and overall cost 8 times as much. And that seminal piece of work has actually been replicated in a number of different places since. So for example, this piece of work in 2013 that focused on an area of London, and every time that piece of work has been replicated, we've had similar results. So now we've got to stop and think about why A&E attendances and admissions have been rising. So obviously, we've already talked about the background rise in homelessness, but there's also increasing complex health needs and increasing barriers to healthcare. And I'm going to talk about both of those in turn. So in terms of complex health needs, I'm sure it won't surprise you that people experiencing homelessness have higher levels of mental health problems. Now, in some cases, that might not be diagnosed and they might not be in treatment. But the survey here was done by Homeless Link in 2014 and asked around 2,500 homeless people lots of questions about their health, and 80% of survey respondents said they thought they had some form of mental health issue. I'm sure it also won't surprise you to know there's high levels of substance misuse in the population. And St Mungo's in 2018 estimated that 60% of people sleeping rough in London had a drug and alcohol problem. And rather shockingly, the Office of National Statistics has been looking at death certificates that mention homelessness. And in the last 2 years, 40% of all deaths have been attributed to drug poisoning or overdose. But in addition to mental health and substance misuse, people experiencing homelessness have higher levels of physical healthcare problems. Now, some of those might relate to their substance misuse, for example, abscesses, hepatitis C, endocarditis, but some of them are the chronic diseases that we all experience. So, for example, people experiencing homelessness are 2.5 times more likely to have asthma, 6 times more likely to have heart disease, 5 times more likely to have had a stroke, and 12 times more likely to have epilepsy. But as you can imagine, with substance misuse and mental health issues, then those can become a lot more difficult to treat. And this interplay of physical health, mental health, and substance misuse is generally called trimorbidity. This graph goes back to those chronic diseases. Now, what this graph shows you is the difference between the most deprived areas in England and people experiencing homelessness. So IMD means indices of multiple deprivation. So what you can see in this graph is if you live in IMD 5 areas, the most deprived areas in England, then your health is probably worse than if you live in IMD 1. And there's been lots of work from Michael Marmot recently about that. The red bar represents people experiencing homelessness. So you can see that actually, if you're homeless, you fare much, much worse actually than somebody even living in one of our most deprived areas in England. And the paper that this comes from also talks about young olds. And what this is the fact that not only do people experiencing homelessness have higher levels of chronic disease, but they suffer disability at an earlier age from this. And infectious diseases are also a massive issue for this group. So hepatitis C, for example, is 50 times higher in homeless groups. But TB is also 34 times higher. And if you look down in the corner there, that's a photo of the Find and Treat chest x-ray screening van, which goes around in London to hostels, day centres and supruns and screens people for TB. Although at the moment, the van is also being used to screen people for COVID and many other things as well. So hopefully you're realizing that there's quite a complex picture with people having often multiple conditions. But I think it's important to say that when someone comes to A&E, they won't necessarily come with all these things. They'll probably come with something like a broken toe. And their priority will be the broken toe because it will be painful and it will be stopping them walk. And then their next priority might be a sandwich because they haven't had anything to eat. And their next priority will be, for example, wanting to get somewhere to sleep. And things that are sitting in the back, so for example, their diabetes, their dental problem, their DVT, their skin problem, their mental health, all of those things probably won't be a priority for them and they won't tell you about them. But that doesn't mean that they aren't there. And it's really important to ask questions to see whether you can help. And it's also important to note that lots of people experiencing homelessness might have communication difficulties that are related to physical degeneration. So, for example, we know a high percentage of people in the homeless population have suffered a head injury in the past. And we also know that alcohol-related brain injury is common. Now, the symptoms of acquired brain injury are memory loss, confusion, impaired attention, difficulty processing information, reduction in initiative, depression, irritability, all things which would make it really quite hard, perhaps, to articulate what one's health problems are and what help one might need. And this is often exacerbated by the most common mental health problem being a personality disorder, which is now often called complex trauma. And personality disorder is about having acute psychological distress. And this one study estimated that actually about 70% of single homeless adults meet the criteria for personality disorder compared to 4% of the general population. And this psychological distress primarily comes from adverse childhood experiences. And if you don't know much about adverse childhood experiences, I'd recommend that you click through on this link and go to the Fair Health training, because it will really help you understand what people have been through and what impact that might have on their psychological development. But in summary, it causes issues with trust and disturbed thinking, impulse control and emotional regulation, and it makes it really hard to communicate effectively and prioritize, which adds to all those other communication difficulties that people might have. And just to say, suicide is a real risk for this population. So, moving on from the chronic health problems people have, we've now got to think about the healthcare barriers that people experience, and that those healthcare barriers are often particularly to primary care. So, for example, we know that around 15% of the general population have a literacy level lower than 8. But when we come to homeless populations, it can be up to around 30%. So if you have to offer forms, it's really important to ask people if they can read and write. With language, lots of people in the homeless population don't speak English as a first language, and the NHS standard is that even at reception, people should automatically be offered telephone interpreting, but sometimes that doesn't happen. There are simple barriers like poverty. Often people don't have credit on their phone and can't phone at 8 o'clock in the morning. There might be mobility issues. Digital exclusion. Currently, at the moment, lots of practices are still on total triage and remote by default and are starting to depend on things like video consulting. And in a lot of cases, our clients don't have the skills to do that. We've talked about mental health and addictions, memory problems, cognitive problems. And sometimes there are practical challenges. Like, for example, if you're a single homeless person and you have a dog, what are you going to do with your dog when you go in for an appointment? And homeless people also talk about power dynamics and feeling like sometimes that they don't understand when they go into the surgery, and that makes them nervous. And there are lots of system level barriers too. We know that patients are stigmatized and there is lots of prejudice. The medical reductionist model means that health services are set up to deal with one problem and one problem only. So the person who come with their broken toe, but who has lots of other things in the background, the service isn't set up to draw those things out. We know that people are turned away repeatedly from GP registration, despite the fact that you don't need ID or to prove your immigration status to register with a GP, but we'll come back to that in a minute. NHS charging regulations are putting some people off accessing care, and that can sometimes even be British nationals, because if you think that somebody is going to think you're from abroad and that you might get charged, this can be very off-putting. In the NHS, we're supposed to make every contact count, but for some staff, who feel perhaps exhausted and they're very, very busy, it can be very difficult to do this. And also it can be very difficult to think about how to do that with somebody with multiple complex needs. So this links to the last point, which is CPD opportunities for people to kind of think about how they can help clients like this are quite limited. Just coming back quickly to that GP registration rules, I'm sure it will surprise some of you, and we're going to come back to this in module 3 to see what you can do to help. But it is important to note that there is no regulatory requirement to provide identity, address, or immigration status to register a GP surgery. And patients don't need to provide an NHS number. An inability to provide documents is not a reasonable grounds to refuse registration. And if you want to know more about this, you can click through onto the British Medical Association site, and it will tell you all about this. Now, I'm sure you know that many GPs do ask for this, and you will come across people who have said they haven't been able to register at a GP. So as I said, we'll come back to it in module 3, what you can do to help. So what's the result of all of this? Chronic health problems, difficulty accessing care, more homelessness. Well, I'm afraid the result is that the mortality statistics are dreadful. So in 2013, the Office of National Statistics started to monitor death certificates which mentioned homelessness. And in 2019, there were 778 deaths that they saw, and this was a 7.2% increase on 2018. The really important thing to note from this is the average age of death. So the average age of death for this group was 46 for men and 43 for women, when the general population age is 76 for men and 81 for women. And if you only take one thing away from this presentation, this is probably the most important thing. This really underlines the poor outcomes of people experiencing homelessness in England today. So what can be done? This is the important thing. So module 2 will explain some of the key aspects of housing law and how professionals in health might be able to help. And module 3 will provide you some top tips for interventions that will help people experiencing homelessness when they come to hospital. But I just wanted to talk to you about the pathway model, because we here at Pathway believe that actually for hospitals where there are high numbers of homeless people attending, that actually what you need is multidisciplinary, multi-agency care coordination in hospital. This is called the Pathway model, and it's a national approach. The first team was launched in 2009. We now have 11 teams and many more coming online. And the Pathway model has been cited as best practice in the NHS long-term plan. The approach includes bringing a specialist inclusion health GP into the hospital to be supported by an MDT team, often with occupational therapists and social workers as well as nurses. There's a ward round with community partners at least once a week. And the overall approach is focused on long-term health gain as well as housing. And it's also important there's a focus on involving people with lived experience as workers on the team wherever that is possible. And the approach aims to stop the revolving door by using a holistic health approach and making sure that all the health problems have been dealt with, building a trusting relationship through a psychologically informed approach, providing expert legal knowledge in housing, immigration and health rights, and you'll get to see a little window into that in module 2. Arranging appropriate housing and support that will support long-term health recovery, hopefully, and enabling and ensuring health follow-up is provided for all health conditions. And I'm sure that you can see that actually a lot of this is not normally possible when somebody comes to hospital, hence the need for a specialist team. So if you're interested, there's lots of evidence that supports the pathway approach. And Lots of evidence to show that it improves health outcomes for people, but it also improves hospital capacity and is cost effective. And down in the right hand corner there, that's us winning the Kate Granger Award for Compassionate Care in 2016. So do get in touch if you're interested. Just to say that this approach to improve healthcare for people experiencing homelessness is part of a much wider movement. So inclusion health is a movement that tries to improve health outcomes for all people that are suffering health inequalities, and specifically those at the sharp end. So that includes people experiencing homelessness, but it also includes other groups, for example, Gypsy Roma traveller communities, sex workers, people leaving prison, vulnerable migrants. So if you are interested in improving care for all of these groups, please do come and join us. There are 3 clinical networks: the Faculty of Homeless and Inclusion Health, the Queen's Nursing Institute Homeless Health Network, and the London Network of Nurses, Midwives and Homelessness Group. Although these were all started by clinicians, they are open to absolutely anybody, and we would really like to see healthcare assistants, receptionists, all sorts of people join in these networks. And through them, you'll get free newsletters, access to free training, and you'll be able to join with other like-minded people and see what you can do. And also, just at the end there, just to highlight Fair Health, which is supported by Health Education England, which provides lots more free training, and the London Homeless Health Programme, which has got lots of free resources. So finally, for this module, I just wanted to leave you with this quote from Michael Marmot. And it might look quite complicated, but essentially what he's trying to say here is that we need to do more for those that have less in order to redress the imbalance in health inequalities across the UK. We really need to go the extra mile to ensure that things are levelled up. So hopefully this will have inspired your interest to join us, and also to do module 2 and module 3. So that's it for module 1. We've got 5 questions. What I'm going to do is I'm going to read out each question, and then I'll just give you 5 seconds to reflect on that and then tell you what the answer is. So question 1, which of these groups of people would be classed as being homeless? A, people living in homeless hostels. B, families living in bed and breakfast accommodation. C, people sleeping casually with friends and family who have no permanent place to reside. Or D, all of the above. So I'm sure you probably know that it's D, all of the above. And I put this question in just to emphasize the importance of the concept that it's not just rough sleepers that are homeless. A wide variety of people are homeless and suffer poorer health outcomes as a result. So it's really important to try and identify people that are homeless when they come to hospital. So question 2. The number of people said to be at risk of homelessness in England in December 2019 by Shelter was A, 2,800, B, 28,000, C, 200,000, D, 280,000, or E, 300,000. So the answer is C, 200,000. 280,000 was the number of people said to be homeless in England, with 200,000 being the additional number threatened with homelessness. And 300,000, if you remember, was the number of people that the big issue said was hidden. So these were the hidden homeless people. And this was just a reminder that the numbers of homeless people in England, are probably over 500,000, maybe 750,000, maybe 1 million. Question 3, what does trimorbidity mean? A, having any 3 medical conditions at the same time. B, having a physical healthcare problem, mental health care problem, and addictions problem concurrently. C, having a mental health problem, learning disability, and addiction problem concurrently. D, it means the same as comorbidity. Just realised that it says addition, but not addiction there, but you'll know what it means. So the answer is B, having a physical healthcare problem, mental healthcare problem, and addictions problem concurrently. And it's really important to note that when somebody does have these three things, that it may be more challenging to treat them, but that means that we need to go the extra mile to help. Just to say, occasionally trimorbidity is applied to C, having a mental health problem, learning disability, and addiction problem at the same time. And some of the same things apply in the terms of those conditions can be harder to treat in that context. Question 4. What was the average age of death for a homeless man in 2019, according to the ONS data? A, 64 years old, B, 55 years old, C, 46 years old, and D, 43 years old. So hopefully you will have remembered that it's C, 46 years old, and this is a really shocking statistic, and hopefully something that you will take with you from this presentation. This is not acceptable, and we really need to make sure that people experiencing homelessness are engaged with healthcare so that we can improve their outcomes long term. I'm sure you will have probably remembered that 43 years old is the average age of death for women. And in the general population, women live longer. So it's really important to focus particularly on homeless women who have such dreadful outcomes. Question 5, the last question. What identification do you need to register with a GP? A, proof of name. B, proof of immigration status. C, proof of address. D, all of the above. E, none of the above. So hopefully you will have remembered that you don't need any of this. And I know you will meet people who have been refused from GP registration because of this. But please do come back and watch module 3, which will talk to you about what you might be able to do to help somebody if they have been turned away from GP registration. So that's the end of module 1. I hope you've enjoyed it. I hope you've learned something. And please do take time to do other modules, module 2 and module 3. And if you have any questions at all, please do get in contact. Many thanks. Bye-bye.